Thank you. I'd like to welcome you to the Health and Wellbeing Board virtual meeting for the 23rd of March. Just some preliminaries before we start the actual meeting. There's a number of councillors and members present at the meeting. Can I ask you to introduce yourselves if you come in to speak on an item? Can I also refer you to the published protocols of holding virtual meetings? If you could keep your phones on mute. There's nothing worse than a vibrating phone when people are mid-flow on a presentation. If you could keep the members of the panel keep their videos on, but keep your microphone muted. If there's a technical problem, the meeting will adjourn until resolved. If it's a technical problem just affecting me, then Genevieve will take over the chairing of the meeting, as who's the vice chair of the meeting. I just want to go by the meeting is being video and audio recorded and will be available to watch and listen on the website at a later date. And also there's a supplementary report, or one of the presentations will also be on the website by this afternoon. It will be used by Carol within the presentation. At lunchtime today, there is a minute's silence for us to take a moment to reflect and to remember everyone who has died during the pandemic. I'd like to propose that we aim to conclude the business of this meeting by around 10 to 12, to give us a few moments to if anyone wants to say anything at that time, and then we can join the minute silence at 12 o'clock. Is that okay? Thank you. We can say more at 10 to 12 about the past year. The attendance by reserve members, there aren't any, none have been notified. We've received apologies from Sheikh Ulaydin. Are there any other apologies today? No, there's no one indicating. Declarations of interest, they have been published on the website as a document. If you become aware of a pecuniary or non-pecuniary interest while the meeting is taking place, could you let me know and we'll record it at that time. So now we move on to the minutes of the meeting. Do you agree the minutes of the meeting held on the 24th of November 2021? Excellent, thank you. Moves on to petitions. None have been received in advance. Is anyone want to present a petition? I see a hand's gone up, but I can't see who put it up.
Apologies, Councillor Henson. James Walters from London North West Healthcare, and I'm just bringing the apologies of Mr. Simon Crawford, our Deputy Chief Exec, who I'm deputising for today.
I'm afraid.
Okay then, thank you very much.
Don't work.
One moment, make things have a bit. So that moves us on to the.
I'll just sit up here with you.
She's having a bit of trouble getting onto the meeting, so I just sent her the invites. So that moves us on to public questions. We have received one public question from Eileen. Is it Eileen Leon? Eileen, are you on the call? No, Eileen's not on the call. What we'll do then, we'll arrange for the response to be sent directly to Eileen after this meeting. That moves us on to item 6, which is deputations. None have been received. We now move on to item 7, and before we do so, I'd just like to say that we've gone through quite a struggle in the last 12 months, and we have, instead of having written reports to a lot of these meetings, we've been doing it through presentations, which I think has worked exceptionally well. We've had up-to-date information, and we can actually question around some of the presentation, which is live information. So it's been most welcome. All these presentations are available online on the council's website, and if anyone needs any, we can send a link through. So now, if we move on to item 7, which is the Integrated Care System Consultation and Progress Report. I believe that's going to be introduced by Simon. Is it Simon Morica? or Claire Kennedy to present the report.
Thank you very much, Councillor Henson. My name is Simon Morioka. I'm one of the managing partners.
Oh, welcome. Thank you.
At an organisation called PPL, which is a social enterprise that's been working to support integrated care development in London and elsewhere in the UK. And I'm joined, as you say, by my colleague Claire Kennedy, who is the other managing partner. I will just bring up, if it's okay, as you say, there's just some slides which I will talk through rather than to each detail, because they are in places slightly dense. And it's possible that this may raise more questions and answers at this stage, but hopefully we'll give the board and people listening just a sense of where this agenda is. You may be aware that when the NHS long-term plan was first published in 2019, there were a number of other documents developed in parallel which talked about some of the potential legislative changes that it was felt might be required to improve the way in which health care and other services work together. And understandably, a lot of that development work was then put on hold in February of last year as the pandemic started to take a grip in the UK. However, what was not put on hold was a lot of the work that actually was happening on the ground. And I think we've seen a dramatic acceleration of collaboration between primary, community, acute services, adult and social care, children's social care and public health as part of the pandemic response in Harrow and elsewhere. So in November, when NHS England published its latest document on integrating care, in many ways and explicitly within the document, it is trying to play a bit of catch up with what's actually happened since the start of the pandemic and the ongoing developments around the coordination of services and outcomes that have happened. So in reading the integrating care document that was published in November last year and which has been the subject of discussions between the partners in Harrow since, there's obviously a lot which we would recognise and I think welcome positively, not least in the recognition of the importance of partnership at a place level between the NHS, local government and voluntary community services, and the focus on population health and tackling inequalities, including a new triple aim for all NHS providers, which basically covers the improvement of health and wellbeing, the quality of the services being provided, and also the need to ensure financial sustainability. So there is a lot, I think, which has been welcomed in these proposals. I think it's also worth saying that in the feedback from across partners within Harrow working in the health and care space, and I know a number of the NHS provider colleagues also submitted parallel responses to the document, which were considered as part of this by the Harrow Health and Care Executive and the Joint Management Board in Harrow. There are some areas where really the devil is in the detail. So whilst the overall direction of the document is both welcome and consistent with what's happening at a North West London level and within Harrow, clearly so much of what has been achieved through positive relationships, through local accountability, and through the principle of subsidiarity. So ensuring that decisions are taken as close as possible to the people who are affected and around their needs and the assets and opportunities that sit within Harrow. So in any legislative change, obviously it's very important that that change supports and does not hamper the development of those relationships, and that there is clarity around how any new arrangements will accommodate and help to further develop some of the good work that's been going on locally, as well as addressing some of the potential remaining barriers. This is a rather it's an attempt to distill into one page some of the key elements of the white paper. And I probably should just say that the white paper that followed on very swiftly after the integrating care document that NHS England produced last year, the white paper was published in February this year, is reflective of a number of the ideas that were suggested in the white paper, in the integrating care document. But obviously, as we know, through the process of developing the white paper, and this is obviously an ongoing process as it becomes a bill and then an act, A number of other ideas and inputs have come in. And one of the key changes between the original integrating care document that was looked at within Harrow and the white paper that's now been produced is around this idea that the integrated care system, and obviously when we're talking about the integrated care system, we're talking the system at a North West London level, will have two statutory components to it. The first being an NHS body that will be responsible, if you like, for the kind of day-to-day operation of health services within North West London and of achieving financial balance within North West London. And then the Health and Care Partnership, which will bring in representation from health, social care, public health and other partners, with that much broader remit of looking at population health inequalities and coordinating joint working. So the two of those future structures are within the white paper together referred to as the ICS. The equally important component of the white paper then is the focus on place and understanding within each integrated care system. There will be a number of place-based joint working systems that are operating. And again, the white paper does reflect this principle of subsidiarity. So a sense that in the practical experience of delivering better coordinated person and community centred care is that happens at a local level, and therefore any future systems for integrating care and delivering the triple aim need to recognise and support place-based arrangements. The other big development from both within the integrating care paper and the white paper is around commissioning, and members may have read or picked up on some of the conversations that are going on around this at the moment. This is the biggest change to the way in which health services operate in England since 2012, and it explicitly removes some of the requirements for the NHS and public health services to commission in the way in which services have been commissioned over almost a decade now. The key thing, and I think one of the reasons why at the moment we probably have more questions than answers, is that whilst the white paper proposes that the NHS should be free to make decisions on how it organises itself, it does in a way that leaves open quite a number of decisions about where and when and how future planning, delivery and assurance of services will happen. So what we know is that within what we call commissioning of services now, there are a whole number of functions which will still need to continue in the future and may actually need to be become even more important in the context of joint planning and joint delivery of services. Some of those will be happening at the ICS level, some of them will be happening at a place level, and how in practice those decisions will be made and aligned remains one of the big open questions of the proposals to date, and something which we know will be subject to further guidance and I'm sure further debate over the months to come. Again, I won't talk through all of the detail on this slide, but essentially to say that one of the key decisions that is proposed within the white paper is that, broadly speaking, NHS trusts will remain separate statutory bodies. So this means that we have new statutory bodies being created within the NHS around the integrated care system, but we will also continue to have NHS trusts which will have their own statutory responsibilities. So again, how in practice providers will come together both within the provision of NHS services, but also to work with local authorities and the voluntary community sector is very much open for development within the new framework. And similarly, and I think positively, one of the things that the white paper recognises is the important role that health and wellbeing boards have played over the development of health and care services in recent years. And specifically that within the future architecture, health and wellbeing boards will remain the place where local partners come together to develop a lot of the strategic analysis that will underpin the work of the ICSs. So the developments are, I think, again, broadly positive, but there is a lot that is left within both the integrating care paper and the white paper to be determined as to how, for example, place-based partnerships, such as the one in Harrow, that has been recognised, I think, now across London as being one of the leading examples of how health, local authority and voluntary community sector partners are coming together to improve outcomes in the local community, will operate within new statutory arrangements for the integrated care systems that sit at a North West London level. And also, I think equally importantly, how developments around things like primary care networks within boroughs will operate and influence at both the place and partnership level. There are within the white paper provisions for joint committees to be established and encouragement of the appointment of joint directors to help facilitate and foster more partnership working. But again, a lot of the detail is left to local places to determine. And again, in terms of the conversations which have been had within Harrow at the Health and Care Executive and at the Joint Management Board, there is a recognition that further guidance is expected. The timelines for these changes, although obviously they are subject to the parliamentary processes, in both the NHS's proposals and in the white paper, are quite rapid. So looking at implementation from April of next year. And I think it's very likely that the proposals as outlined in the integrating care paper will form the roadmap for the way in which NHS services are planned over the next 12 months. So even in advance of legislative change, the integrating care paper makes it very clear that a lot of this can be achieved within the existing architecture. It's unlikely that the final proposals and final structures will be fully set out before the legislation is passed through the various parliamentary stages. And it is very likely that there will be further flexibility even then in terms of how local place-based arrangements are organised. So really, in conclusion, in terms of just introducing where we are on the consultation and the feedback, given the critical nature of the services that are being delivered now jointly, given the priorities around recovery and dealing with many of the previous inequalities that have been highlighted by COVID, but also the impact on all health and care services from the pandemic, there is, I think, a strong sense within Harrow, within the partnership, of the need to continue to develop local structures and responses, even in the absence of that broader guidance, and recognising that there will be further proposals from the government around things like social care, mental health and public health later this year. If it's okay, I will just stop presenting at that point, and Claire and I will be very happy to take any questions or thoughts at this stage from anybody on the call.
Thank you, Simon. That's very well presented, a very complex sort of changes to the health service that we're seeing. We've got some comments later on, but Gazantha, you have your hand up.
Yeah, thank you, Chair. Thank you, Simon, for this presentation. I'm sure it takes a lot of hard work. Just a few clarification on finances side, like financial control, or who is going to look after? Is it going to be independent body? Are the local authorities going to be involved in it? Because we don't want to go into debts, you know, like in past CCG went into quite a bit of debt, so we don't want this to happen again. And my second question, Simon, is again on the powers to remove or commissioning of NHS and public services. How it's going to work? Is the local authorities again going to be involved in there? Thank you, Simon.
Did you want to take that one first, Simon, or did you want all of them together?
I'm happy to take them one at a time, if that's okay, Councillor. So, and I might defer some to my colleague Claire as well. So just on the financial controls, I think it's a very good question. In essence, the white paper establishes two separate sets of statutory responsibilities. So the NHS body within North West London has a statutory responsibility under the new legislation to ensure that the system is in balance across North West London. But as mentioned, the individual NHS trusts that make up North West London retain their individual responsibilities for ensuring that they are being managed in a financially sustainable way. And overarching all of this, the triple aim introduces alongside a commitment to improving health and wellbeing outcomes and services, a requirement for the NHS to be financially sustainable. So it's quite a complex landscape of overlapping responsibilities for finances. And obviously what we know alongside that is that whilst we have a bit more clarity today than we'd had even a few weeks ago around the funding for the NHS in the next year, there's still a huge amount of unclarity around social care funding and the future of social care funding across the country. So I would say that there is a big focus on finance, but that is definitely one of those areas where how those overlapping responsibilities will be implemented in practice remains very unclear, and something that will be needed to be clarified in further guidance. Just in terms of the powers on commissioning, I think the changes have broadly been welcomed in terms of some of the unfortunate disbenefits, if you like, of putting health and care providers in competition with each other. However, we know that there will be challenges in terms of the quality of services, in terms of how different potential services are delivered, and it will need clear and consistent planning across Harrow to make sure that Harrow residents get the best of the services which are on offer from the different providers, and that those services work together towards shared priorities around health and care outcomes, which is why the Health and Wellbeing Board, the place-based partnership boards, will continue to have a really important role in setting the priorities and the planning agenda. There is then some work to be done to understand how community acute and primary care trusts can come together to deliver that agenda for you.
Thank you. We only have two other hands. If we take both questions, because we've got three other big reports to come along as well. So we've got Christine and then John.
Thank you, Chair. Thank you, Simon. That was a really helpful report. I had the experience of living through Lansley when I worked in the NHS. And I believe that there is a lot of positive partnership work locally, so that locally we've been task driven, but also I think that locally we are going to work this through. My concern is what I remember of Lansley is I remember maps trying to see where the divil things were supposed to link into each other and who fed back to whom. And it was an unthought out nightmare. So my concern is not locally, my concern is fuzziness higher up the trees. And how on earth is that going to be resolved? So that's one thing. And the other thing is, obviously, I also lived through the fact that nobody had the common sense to get rid of the internal markets within the NHS. But my concern is if internal markets are kind of phased out, that we are going to be overwhelmed by private providers, and I am very, very worried about that. So if you could encompass any of that in your answers, I would be very grateful. Thank you.
Thank you, Christine. And John?
Thank you, Chair. Yes, thanks, Simon, for that presentation. It's certainly a lot of complex information to take in. I suppose the theme on partnership and the collaboration across the NHS and with local authorities is that culture is very welcomed, and we've seen over the last year the benefits of that in terms of being able to respond to COVID in a prompt and effective way. I suppose for me that it does, looking at the diagrams and what have you, it does look like organisation upon organisation upon organisation in terms of statutory organisations, but there's very little there about where the voluntary sector fits in, and or obviously the voluntary sector is quite diverse, so some parts of it are effectively advocacy organisations, some parts are provider organisations. And one of the things that we're one of the things that COVID has really thrown up is that sometimes small is better. We have to be responding sometimes at the small level as well as the big level. And the inequalities for BAME communities and others have really come to the fore. So it's hard to see how NHS organisations as big as they are and as powerful as they are, working on their own, are going to be able to really make inroads on things like health inequalities and working directly with communities. So it's just an observation. I'm not expecting you to have a complete answer, but it is stark that there's very little on those diagrams around where communities and voluntary sector fit in, really. It does feel like the big boys are leading the show, as it were.
Thank you, John. And there's one final question coming from Chris.
Yes, you talk about place-based partnerships, and I think probably you tend to mean sort of partnerships based around local authority areas. There's quite a lot of other different shaped partnerships out there. So the Child Death Review Partnership, the Learning Disability Review Partnership. We're soon to have a pan-London domestic abuse strategic group. We're about to go into a serious youth violence homicide review group. All of them have potentially got different shapes. Have you built into the system, or are you building sufficient flexibility so you can actually respond to all of these shapes and sizes of different partnerships? Because they're not, it's not sort of Northwest London or Harrow. There's a whole bunch of others as well that sort of got different shapes to them. Thank you.
Thank you. And we've got one more question from Genevieve.
It's not a question, it's a comment. You can either take it now or after Simon's given his answers.
Actually, if Simon could respond, then if you could comment on it, Genevieve, because and I would as well, from the position we hold within the ICF.
Thank you.
Simon, did you want to respond to those questions so far?
Thank you. Claire, did you want to go first? And then I've got a couple of specifics that I'd like just to quickly pick up on.
Yeah, I think the key theme, sort of, I would say, in overall response to all those questions, is it really highlights the importance of the place-based nature of the response, and how things happen within a place is one way of counteracting Councillor Robson's query about what's happening up the chain. And I think that we would all recognise that can be a challenge, but that managing things within a local place and having the ability to interact at the various levels locally is a really critical way of helping to respond to that. And I think the other point I just wanted to make in terms of the different kinds of partnerships, I think that John was talking about in terms of different partnerships across the pieces. I think that is a challenge. And again, I think the different lenses that are in play are really important, because I recognise obviously there's a lot of challenges around different kinds of communities. There are communities that are place-based, but there are obviously lots of different communities that transcend place. But having a strong root within a particular geography and being able to use that as a lens through which to interact with the variety of different communities that may cut across in a very complex Venn diagram, I think again just highlights the importance of almost turning the whole perspective around, so that instead of looking top down, it's a bottom up perspective.
Yes, I would just, just to echo that. So one of the things I think we've seen in Harrow over the last 12 months, which has been one of the most impressive developments in the context of everything else that's been going on and the pressures around the pandemic, has been the development of the primary care networks and the way in which GPs within Harrow have, alongside colleagues from the voluntary community sector and from the local authority, taken a lead role, not just in helping to safeguard and ultimately to vaccinate members of the population, but also to continue to develop thinking around areas such as frailty, which we know are part of the long-term solution to many of the pressures facing our public services. So I think that there is a real commitment across Harrow and across all of the professional and frontline colleagues who are working in Harrow to start to bring things together in a way that is of immediate benefit to people living in the borough and isn't simply about structural change. And I know, talking to a colleague in another part of London, one of their success criteria for the next 10 years is that in 10 years' time, they don't have to go through another reorganisation of the NHS. So I think there's a real opportunity to take this one by the reins and make sure that it does reflect the needs of the local population. The other thing I was just going to say, again, just on that question about the different layers and things that things are happening at. So we're currently supporting RM partners developing the Cancer Alliance strategy for West London, which includes Northwest London and Southwest London. I know that there are many developments going on, and I think learning disabilities is a really good example where best practice is being shared across geographic boundaries. And I think that is an absolutely critical part of responding to the challenges that are facing all areas of London. So we do not need to reinvent the wheel necessarily, but as Claire says, the key thing is how those regional and sub-regional and national even strategies are translated to a point where they're actually starting to have a meaningful difference for people who are living within particular areas. And that's, I think, the role of the place-based partnerships, but also all of the organisations and individuals within those partnerships, is to help to take the best practice and make sure that that is everybody's experience and not just the experience of a select few.
Thank you, Simon. Genevieve.
Thank you. So I just wanted to say that if I had seen this iteration of what the future held a year ago, I would have been completely daunted by the expectation that was set in front of us, because although we were having good, strong conversations in Harrow and across Northwest London about how we wanted to come together and deliver care in a more integrated way, I think we still had quite a lot of the development to do. One of the benefits of COVID, if I could make that comment, is that it has driven forward partnership working in Harrow and across Northwest London, if I'm honest, as a catalyst as never before. And the conversations that we now have at the place of Harrow and at Northwest London are so much deeper than we were previously having. So all change is difficult, and you know, at the end of the day, this reorganisation would see the end to you know, a structure that I have known and loved. So it would make for you know, quite a significant change for us. But I do actually strongly believe that this is a way forward that potentially, as Simon says, as an aspiration, could work in the long term without a need for further reorganisation, because it is actually embedded in combined relationships and a strong location of place. So I do see it as a positive change, but of course it's up to all of us to make that change the best it could possibly be.
Thank you. I agree a lot with what Genevieve has said. We've spent the last 2 years trying to build the relationships, improved relationships, I think, in a challenging world. And I think those partnerships and what was developed in Harrow is shown, you know, how we got through the COVID pandemic. Is a lot of it was through the partnerships that we built in that time, and the trust, which is an important part of that, is what's key to how the ICS will work. I do have some concerns. I sit on the board of the ICS for Northwest London, representing the 8 boroughs, and Sean Harris, who's chief executive, also is involved at that level, and I think Genevieve is as well. You see, so we have quite a lot of input into some of these things that are going on, and for me, the ICS is a good way of working. So it talks about partnership and collaborative sort of approaches. My concern about the white paper, I think, which Simon was sort of alluding to in some sense, is if it's not properly funded, then we've got serious issues ahead. You know, Harrow has been regularly underfunded across the health service. Now we're very low on the lower quartile of funding per resident compared to some boroughs are. And sharing that out across 8 boroughs means that, yes, we will probably gain, but that would be at the expense of someone else. And that's what would make the challenge. And I don't think you can make the savings required just through commissioning services in a different way. It's, you know, we've got rising demand on services. The important part is for the ICS, the priority over the next 18 months, 2 years, is around tackling poverty and health inequality. And that needs the partnership to work properly, right through to the PCNs, Genevieve said, right through to councils and the NHS. You know, and as Carol Furlong would say, the wider determinants of health is key to all of this going forward. But my concern is what comes out of the white paper, and I think we need to make sure, you know, we'll come back to this board again, but it's making sure that that we cover everything that we need and respond accordingly, because there's some few things coming through that I think might upset the partnership in that extent, and I wouldn't want that to happen. So the recommendation on the report is to note the updates. So I thank Simon, and is it Claire, isn't it? I think If I could just yes, if I could thank Simon and Claire for the presentation. Can we note the report has been done? Thank you very much. It's very informative, and it will come back again a future iteration. We now move on to item 8, which is the adult social care budget, which is a pressure within the system as well. So this is going to be presented by Angela Morris and Don Edwards. So who's going first?
I'll go first. Thank you, Councillor Henson.
Angela, thank you.
Okay. Thank you. So Angela Morris, I'm the Director of Social Services for Harrow Council. So just by means of an introduction, before we start the slide pack, I just wanted to say it's obviously been an extraordinary year, and that's both the personal impact and the loss in the community, but the impact on the budget and adult social care as well. We've worked extremely hard to try and mitigate the financial impact, and we've made the most of additional expenditure, additional grants that have come in to cover and try and mitigate some expenditure. But it does feel like treading water at times through the year, being able to do that, and to take advantage of the additional monies that have come from the Department of Health and Social Care. It's been quite time consuming in itself to do that, but it was critical for us to do that because we had to support our providers who faced a huge pressure on them at that time. As you'll see from the slides that Donna and myself will go on to present, it has been extremely difficult to forecast. It's been very fluid through different times in the pandemic, and we've needed to react very quickly in an agile way to support our citizens in this difficult time, and our providers who have done a magnificent job. And that's mainly been in the forms of ensuring that PPE was supplied to our providers, we had the right skill match, and we worked very closely as an integrated approach to that, making sure we had the right skill match to support our providers. So that's both from the social care element with the PCNs and North West London nurses to make sure that we could support them in this difficult time. We've also had to increase, as you'll see from the slides, at different times in the year, the amount that we've had to put forward for placements. So that's both our nursing and residential placements and the domiciliary care placements. And there has been also an additional cost in staffing. And we've had to do that at times because it was the right thing to do to support our citizens in a very timely way. So I'm going to pass on to Donna to go through some of the slides, and we'll talk you through them now.
Thank you, colleagues. I will just share my screen. Hopefully you can all see that now. If I take questions at the end, because while the screen's up, I won't be able to see any hands. So apologies for those of you that may have been at the Harrow Health and Care Executive, the strategic context I have lifted from that meeting, but I think Councillor Henson and Angela have kind of referenced the strategic context. I think what's perhaps important really for partner organisations to perhaps just appreciate, and I know many of you have heard me say this at previous presentations, but just the level of grant that you know, the council has actually seen reduced since 2013-14. You know, we used to receive £52 million worth of revenue support grant. That's now only 1.6 million in 21-22. And over that period, we've had demand-led growth, and we've had to deliver savings to account for, you know, both the loss of grant, but also the need for growth. And as Councillor Henson mentioned, we are one of the lowest funded councils, both London and nationally, so that does present its set of challenges within what we've always acknowledged to be a very financially challenged health and social care economy. In terms of the budget for 21-22 and future years, the council, the cabinet agreed its budget in February, and we have got a balanced budget for 21-22. I think it's important to note that in setting that budget, we have had to fully maximise the increases that have been available to councils, both in terms of the council tax at just under 2%. Anything above 2% requires a referendum, and full use of the social care precept. So, recognising the financial challenges, we are increasing the council tax, but being one of the higher funded council tax, you know, that inevitably presents its own set of challenges. You'll probably be aware that we have been allocated additional funding. There was 300 million nationally announced for additional social care funding, but actually when you look at what that means for Harrow, it was only £326,000. So welcome the additional resources, but once you get down to the local allocations, you know, there isn't a lot there for the council to support such additional cost. We have got additional COVID monies going into 21-22 as a one-off. We've got £4.6 million for Harrow, but that's not just for adult social care, that's across the council, and there are a range of pressures across the council. While social care is one of the more significant areas of pressure, we also have quite a lot of pressure in our communities directorate, where we've seen a loss of income, you know, around commercial activity. So, you know, you can see the tension there about how those resources are allocated. Public health grant has increased only very marginally, of which £84,000 has been specifically allocated around sexual health services. So again, not a lot of room for increased expenditure during 21-22. And a reminder that just whilst we've got a balanced budget for 21-22, we have got budget gaps in both of the next two financial years, totaling just under £30 million, which in itself isn't insignificant, given the history of the savings that we've had to deliver against the backdrop of demand, and now more increasingly, I imagine, that kind of customer expectation in terms of the level of support that's provided. So just to give you a bit of sense about where we actually spend the money in terms of the adult social care budget. So our gross expenditure budget for care is just under £86 million. And you can see from this grant that the majority of the care, just under 40%, goes on residential and nursing services, followed by care in the home and reablement services, and then personal budgets. So that accounts for nearly 3/4 of the adult social care budget. And what's left provides supported accommodation, largely to learning disabled citizens. We've got the support for the under 65s in relation to mental health services. And then we've got about £5 million worth of spend on the internally provided day centres and residential care settings. And what you've got left here in this very small chunk are just some of the other smaller aspects, but nevertheless critical to support the adult social care service. So in particular, safeguarding and complaints, how we ensure that we keep our citizens safe. Carers and respite, you know, we don't spend a lot of money on carers and respite, but actually these are some of the areas where we can start to alleviate some of the pressures in the services that we provide directly, and so are very critical that we are able to continue to provide this level of support. And contracts, these are just some of the other services that we commission that support services to service users. So these are things like our extra care support, some of our Care Act services, etc. We spend about just under £1 million on equipment, largely supporting those coming out of hospital or those supporting those to avoid hospital admissions, and then some services on transport. So by far the biggest area of spend on that direct care, which is quite challenging because of the ability to influence the spend, which is driven by, you know, supply and demand. And as Angela mentioned, the care market, the care provider market, has been significantly challenged during the COVID period, supported by quite a number of grants, but on an ongoing basis, that's likely to be or continue to be challenged as we expect different ways of working in response to the pandemic. This next slide just shows you, so this first column here, this is the pie chart essentially, but it's also important to note that our budget is actually lower than that. Our budget is just over 77 million, and the reason it's lower is because we get £24 million worth of income, Just under £10 million of that is through assessed financial contributions for care. As we all know, social care isn't free at the point of contact, unlike the NHS, and individual citizens are assessed personally on their circumstances for what they are able to contribute towards those care services. And there'll be a whole range of assessments there, from those that are assessed as not being able to contribute at all to those that are self-funders. And then we also have a number of grants, which includes the Better Care Fund that comes across directly from Health, and a number of other grants, including the Improved Better Care Fund, some grants for services directly. And then other costs which support the social care function, but which aren't directly attributable to individual citizens, like the care costs here. And these are largely the care management costs, so all of the times of the social workers and the heads of service under Angela's direction, who drive the policy and the service. And then the corporate costs, which are those costs which are allocated to the directorate, which reflect costs such as legal, IT, finance, etc. So a budget of 77.3 million, influenceable spend, which is largely in this care column, but again, influenceable only in the sense that we have to commission those services, and prices will be driven by those providing the services. So just to put that into some context in terms of the number of the citizens that we're supporting. So about 3,000, just over 3,000 citizens supported across all care groups, of which 611 in receipt of those residential and nursing care settings. So that was the 37% and the £32 million. 134 citizens in accommodation settings, about just under 1,300 in receipt of domiciliary care services, and then 622 purchasing services themselves using a cash direct payment. And then for those in receipt of mental health services under the age of 65, just over 400 citizens. And in terms of the support that we provide to carers, we're currently supporting about 511 citizens for caring responsibilities. And on the graph, the pie chart previously, that was just under about £1.3 million in terms of support to respite and carer services. For the eagle-eyed among you, you will notice that when you add up these figures, it doesn't tie up to this figure here, and that's largely because we've counted these citizens in relation to the services they're receiving, and some of them may receive more than one service. So in terms of that adult social care budget, for the adult social care budget that was agreed by Cabinet and Council, we forecast growth of just under £6.3 million, which assumed £500,000 worth of cost reduction through commissioning savings that we intend to deliver, and through increased income. Our charging policy had been more generous than others compared with nationally, and given the challenges on our finances, it was necessary to bring us back in line with the national position, which generated additional income. However, whilst we forecast we needed just under £6.3 million, the second bullet point references the challenge that has been to actually deliver that in the context of the overall budget. So in this financial year, the Adult Social Care Directorate has been allocated 4.3 of the £6.3 million directly into its budget, which reflects a growth on a year-on-year basis. And that includes just over £1 million for provider inflation. However, the balance of that forecast growth, just under £2 million in the third bullet point, has been allocated for social care support. However, it hasn't been possible to allocate that on an ongoing basis. We've got that currently sitting in a reserve, so if we need to draw down on that, we will do. However, what that will do is mean that the council will need to identify that level of funding on an ongoing basis, should that be required, or potentially expect the directorate to deliver savings to enable that level of expenditure to be managed. So there's quite a tension there between managing the council's overall financial position and managing the demand-led nature of the service, which both Councillor Henson and Angela have referred to. I think it's also important just to point out that the budget at the moment includes the Better Care funding at the 2021 levels, because we continue to have a bit of a mismatch between the planning process between setting the local authority budget and the NHS long-term plan. So we are expecting an increase in that, which will perhaps be about a couple of £100,000, but obviously we've not built that into the budget as of yet. I'm going to pass on to over to Angela now, just to touch on some of the risks associated with the budget.
Thanks, Donna. So what we have found over the last year was that the demand has been fluid in a way. So we've had peaks and we've had dips. So initially at the beginning of the pandemic, sadly, the care homes had devastating effects on the care homes, and that actually did increase concern, obviously, in the community. We had people who then were very reluctantly wanted to go into care homes, and we were having to put in higher packages of care in their homes to keep them. There was also, at the beginning of the pandemic, this time last March, there were more families who wanted to protect their loved ones, and so they actually did cancel their domiciliary care packages on a short-term basis, because they wanted to be able to ensure protection for their loved ones. This wasn't sustainable, and what we have found as the year's gone on is that there's been an increase in demand, which has outstripped the initial dip that we had at the beginning. In hospital discharges, we're finding that there's a higher level at the last couple of months, particularly a high level of care required when someone comes out of hospital to support them. That's increased by 30% over the last month. And we are expecting absolutely much more activity to resume in the hospitals, and already has started. And the support we know from evidence previously is that those individuals will need more support in the community. There is a lifetime cost. We've worked, as you've heard in earlier presentations, really closely with our colleagues in health, in the voluntary sector, in the acute setting, and that's really helped. But there is a lifetime cost that's left on the council. So people initially who were discharged, quite rightly, at speed at the beginning to ensure that there were beds available for people coming into the hospitals, were discharged into, there was a different process. Adult social care wasn't involved at the front of that process, and were discharged into nursing homes at a higher rate than we would have normally discharged. Those individuals have been there some time now, and there is a lifetime cost. Although we've come to an agreement in year, which has been very helpful, there is a lifetime cost of those those placements that the council will have to pick up. Our providers have had a huge challenge, both in the voluntary sector and in the independent providers, and they've really stood up to that challenge. Now, what they've had to do is work very differently. We do know that they have incurred expenses as a result of that. So we are anticipating, and there is some market intelligence out there to suggest that there will be a higher request for inflation this year than there has been previously. And as I touched on earlier, the social work practice, we've seen a huge increase, and I know Tanya's on the call here, in mental health, people presenting with mental health problems, concerns. We've had to increase our support through CNWL to make sure that we can respond to that in terms of our AMP service. And also we found, sadly, an increase in domestic violence, and the number of people presenting for the first time to the council for care. Coupled with that, citizens' expectations. It's been very difficult because normally it's always quite difficult. I think the lines between health and social care, it's always quite a shock to some of our citizens that social care is a means-tested service, and that there is a charge applied to that. Those lines have become even more blurred now with the changes in discharges, and people, we're likely to see, we are already, but we're likely to see more challenge in terms of assessed contributions towards care. As I touched on before, mental health, domestic abuse, we've seen large increases in that area, and obviously we work very closely with North West London. We're making, I think, a good comprehensive case as a system in Harrow, but it's very, very clear in evidence that historically there are some inequalities on how the citizens of Harrow have been able to access the health economy.
Thank you, Angela and Donna. That's very comprehensive for prelude to the year ahead, really, of the pressures we face as just in adult social care, about the other pressures that are taking place across other services. But it's important to note, you know, that this is very fragile going forwards. And I think Donna said we might have to draw out of reserves just to get through the next financial year, but that's all putting pressures into the 22 financial year. Probably why we're so keen to get this adult social care bill that we've been waiting for about 4 years now. So we're also keen to see it. Is there any questions on that? Simon, you have your hand up. And then
yeah,
Murray.
I was just going to follow on from you, Leader. Just to say, I agree. We are under pressure. There's no doubt about it. You can see from the presentation, we are under pressure. We have very little wriggle room at all. We are working so hard in adult services to contain costs. We're working hard on our strengths-based approach. We're working hard to try and reduce on that pie chart where the biggest segment was residential care at about 40%. We're working so hard to try to work with our residents to enable them to avoid or delay residential care, because it's better for them and it's better for us in financial terms. But it's so difficult. As more and more people present, as we see the effects of COVID continuing. For us, COVID doesn't end on June the whatever it is, 21st. It's going to go on for the rest of this year and beyond, as more and more people present with the long-term effects of having COVID. And going back to what Graham was saying, and in the presentation prior to this, the white paper in February said nothing except wait till later in the year, said nothing about any plans for social care, for the way it should be organised in the eyes of the government. They have put nothing forward so far, and in terms of funding. And it's so difficult for our adult social care financial teams to plan a year, anything more than a year ahead, when you don't know what the funding streams are going to be. We need to be able to plan over a reasonable number of years in advance, but without surety of what sort of funding is going to be coming, you really can't do that. So it's a bit hand to mouth. Everyone in adult social care is working so hard, our partners are working so hard, and I commend them, but we are feeling the pressure, and really we do await with interest what government has to say about how it sees the solutions in community social care. Thanks.
Thank you. It's nearly 11 o'clock, but Murray and then Genevieve. Murray first.
Hi, Marie Pate from Healthwatch Harrow. Just an observation, really. I don't envy you the task of what you've had to do, because I think it's been a very difficult year. It was really just an observation which you've partly covered in your risks about the citizens' expectations. I'm really coming from the risk to the reduction in service that people are going to receive. And I think that possibly needs to be reflected within the risk just a little bit stronger. I think there is, understandably, I appreciate why there is a shift, but I don't think we can get away from ultimately the residents aren't getting the service they used to get. And there is a shift both in terms of how we communicate that and how they support that. And I will just give an example of the move to online support, which for many may be adequate, but for many it's not. And I just think it would be good if the risks reflected that just a little bit more. Thank you.
Thank you very much, Marie. And Genevieve.
Thank you. So really helpful and clear presentation, Donna and Angela, for really complex concepts, really. I'm conscious that there is also a whole group of people who receive support and care in their own homes through private agencies that perhaps don't always touch on the radar of the local authority, but sometimes when finances become tight, end up arriving on the doorstep of the local authority. And so, you know, that's something that collectively we need to become more aware of, how many people in our community actually are in receipt of any form of care, and not forgetting our informal carers that have done such a fantastic job. I suppose that the topic of inequalities that has been triggered by COVID does also make me really conscious that we would all like to be in a place where we're able to pay our carers a higher amount, and I think that that's not something that's going to be resolved. But you know, we see in terms of some carers across North West London who need to go and get their COVID vaccination, they're not paid for the time it takes for them to get their COVID vaccination, or they're not paid for the travel time that they need to in order to achieve that. And some of them sadly are on a very low wage. Now, I know that's not actually in the gift of the local authority, but I wonder, kind of like in terms of how we think about some sort of aspiration as a social contract with our communities, that how we move our carers into a higher position in society.
Thank you, Genevieve. Donna and Angela, did you want to quickly sum up on the questions that have been raised and the points that have been made?
Yeah, I suspect Donna and I will have the same point here, but I'll see when Donna says. So I think firstly, from Murray, that's a good point about expectations and the move to online support as well as physical support. So absolutely, we're happy to kind of make that clearer actually in future presentations. I suppose it's worth saying that some citizens actually do like the virtual, and some carers do like the virtual because it's better access, different times that suit them. But there are absolutely, you're right, a core who find it very difficult. So we need to acknowledge that. Genevieve, in terms of, it's a good point about the carers. We do have a good quality assurance team. It's absolutely probably the best team I've ever worked with across all the boroughs I've ever gone. They're very tenacious, very enthusiastic. It's headed up by Una Taylor, and all regulated services, it's on their radar. They visit all of them. So even if it was a private agency, they'd have to be regulated. And this team, they do have visits by this team to check the quality. But it's a good point about how many numbers. And if you remember the Dilnot report some time ago, there was that recommendation that we would know about everyone in the system, so we knew when they were coming. And that's still a gap. And hoping that might be addressed one day. But you're right, we really need to get to grips with that. And in terms of carers, again, we do, through the ICP monies, we did make that offer to all agencies, paying for travel time, paying to get there, offering cabs to take carers to there, because it's really in all our interest to make sure that as much as possible all the care staff do receive those vaccinations. And we continue to have weekly meetings with all our providers. As you know, the home care providers have really taken the mantle on that, have gone really far, and our dom care agencies are getting there, but we need to put a lot more energy and push in to make sure they have every opportunity to get that vaccination, because until they get it, we can't guarantee obviously that our citizens are going to be safe. So I think that's covered everything. Donna, did you want to add anything there? No, thank you.
Excellent, thank you very much. Actually, just going back to Simon Crawford mentioned about 18 months ago that the pressure on the adult social care was also put pressure onto the hospitals if they can't discharge, or if they people end up being moved into hospital at fast cost, and that's what needs to be addressed as well in the middle of all this. So thank you very much for the presentation. The recommendation is that we note the report. I think everyone's nodding that we do note the report. So can we move on to item number 9, which is the COVID update, and includes the infection rates in Harrow, the borough vaccination plan, the updated local outbreak plan, and also test and trace. And we have a number of people. Carol is going to introduce quite a bit of this. We've got Lisa Henson and Genevieve as well, also partly contributing on this report. It's 11:05, so could we do it in 15 minutes, do you think, Carol? Carol's on mute. Carol's.
Hi. I'm going to have a good go at not doing that. There we go. So the latest data, this is what our COVID data showed as of last night. We've had 150 cases in the last week, which has been very similar to well, every day of the last week. We've hit a sort of a plateau where we're sort of wobbling around the 55 to 65 cases per 100,000 at the moment. But the good news is that in older people, the numbers have been really coming down significantly. And so we've only actually had 13 cases in the 7 days up to the 14th. If we look at the over 70s, we actually only had 1 case in the over 70s in that time period. So that's great news. And I think that's a testament to the vaccination programme. So I won't carry on with that page. This one just shows you the pandemic as it has been, and shows you a sort of closer update of the last few days. You can see how many cases we're getting per day, which does fluctuate a little bit.
Carol, you've gone mute.
Yeah, you've muted yourself, Carol.
Sorry. Yeah, you see here we've got no cases in the over 80s, and that's been for about a fortnight now. So you know, they were our groups that were ending up in hospital, and you know, and so that's great, really great thing to see. In the 60s to 79s, that number is coming down, and as I said, if we separated that out into the over 70s and the over 60s, you would see that the majority of those cases are in the 60 to 70-year-olds rather than the 70 and up. So that's really good. But the driver at the moment of our continuing rate and why it's not going down is actually the 18 to 24-year-olds, where we've seen this big increase. It doubled from the beginning of March to what it is at the moment, and we really need to try and get that to come back down again. The indication is that it's starting to come down, but it's still way too high. Everybody else, the numbers are looking pretty good. Sorry, every time I press. There we are. In terms of
press the minus figure on just on the top right hand corner of my head, and that might make it disappear.
There you go. Right. Okay. So in terms of ethnicity, we're not seeing a particular pattern of any particular ethnic group that's having a disproportionate number of cases, apart from the Pakistani group, which represent a very small proportion of our population. So those numbers are actually quite small numbers, probably less than 10 people. And then this other group, which is people whose ethnicity doesn't fit into one of the categories. Now that could be because of a typo when it was put in, or because of some other misclassification. And you know, we are trying to get that to improve. In terms of deprivation, we're seeing more cases in the most deprived people, and a lot of that will be because those are the people who actually have to leave the house to go to work. And in terms of the ward picture, it's very variable. So every week there's a different area that's showing to be the highest. And we have some of these sort of really wide variations. If you just look at this data over here for Hatch End, they were one of the lowest last week, and now they're one of the highest. So it is very variable. We are still seeing some deaths from COVID, and we anticipate that this will continue, but hopefully in much smaller numbers than we've previously been seeing. And the good news is that the hospitals are seeing less pressure on the system of people coming in with COVID. There is some evidence that the vaccinated people are not being admitted to hospital in anywhere near the quantities that unvaccinated people are being admitted. And I believe Imperial are hoping to publish that data soon. Just a reminder of my Swiss cheese model. I talk about this every time. There's lots of things that we can do to stop those holes lining up, and so, you know, take all the actions that we can. Get tested if you need to get tested, and in our community testing program, we've got a lot of options where people can get tested. And the newest thing is that we're going to be having testing in community pharmacies. I think there's 16 community pharmacies opening up. I think some opened last week and some are opening this week. That's just a reminder of where you can get tested. And a little word about surge testing. So we identified 2 South African variants in Harrow, and we have been looking at how we can see whether or not we've got a problem. We've been able to ascertain that these people are isolated, and they have both recovered. So that's good news for them. And what we're trying to do is we're doing some surge testing in the areas that the cases live, and in some of the areas where they said they went before they were diagnosed. And so that's 2 areas around Hatch End and Harrow Weald, and also a 3rd area of Wheelstone High Street. And the pop-up testing that we're doing there is continuing. So far, we've done around about 3,500 tests. We have updated our local outbreak management plan, and apologies, it's a huge document and kept crashing the system when I tried to email it out. So in addition to the previous one that you've seen that we published months ago, this one looks at enduring transmission. It looks at inequalities issues, how we do the monitoring and surveillance. The last one was very theoretical about, you know, all of the things that we plan to do. This one is much more based on what we've actually been doing, and, you know, with the learnings that we've had, and how we collaborate more with our neighbouring boroughs and London teams. And with the other organisations like NHS England and the NHS Test and Trace system. And we look at how we've come out of lockdown and recovery and the risks associated with that. And I'm going to pass on to talk about vaccination to Lisa.
Lisa, are you on mute?
Sorry, yeah, I had a sticky button there. Thank you. Apologies for the delay. Oh, sorry, my most up-to-date data isn't in there. Let me see if I can share my screen, but I will start talking in the meantime. Yes, I'm just going to run you through our latest position in terms of vaccination uptake in Harrow, as well as provide an overview of the borough plan for vaccination going forward. Rates, so I haven't got that loaded up to share at the moment. But just, yeah, in terms of our uptake rates in Harrow, we've remained very proud of how our population uptake has been running. And we continue to see high uptake amongst our priority cohort groups. We do still need to maintain focus, particularly in cohorts 1 to 4, to make sure that our most vulnerable patients are protected from COVID through vaccination. And I will go on to talk about the work that we are doing around vaccination hesitancy in relation to that. Sorry, I'm trying to get this presentation up while we're speaking. Just in terms of the borough plan going forwards, so there will be some changes that we are proposing to the way that we deliver vaccinations in Harrow over the coming months. As people know, this is the current delivery model for vaccinations. So we have locally 3 sites providing vaccinations for our residents at the Hive, Tithe Farm and Byron Hall. We don't currently have a mass vaccination site in Harrow, although our residents have been accessing mass vaccination sites elsewhere, particularly at our Wembley site. Working with these 3 sites are our roving teams, so they've been supporting vaccination into care homes and for our housebound clients. And we have started on a fairly small scale at the moment, providing same-day clinics, or pop-up clinics they're referred to, within GP practices, where patients can go to their local practice to access vaccinations. And we currently have 2 pharmacy sites, both of which are in Rayners Lane, supporting vaccination too. If we could just move on to the next slide, lovely. We are proposing some changes to this. One of the main reasons we are proposing changes is that general practice does need to start to transition back to delivering its usual range of services to patients. General practice was asked to stand down non-urgent or non-essential services in January, and we need to start standing those up again because many patients who need routine reviews may have been some time without seeing their GP now. A lot of staff were taken out of general practice setting into the vaccination centres to support this effort. Equally, what we are finding is that a really hyper-local approach to vaccine hesitancy is working particularly well. So what we want to do is strengthen what we're delivering through our local practices and looking at our bigger centre to essentially vaccinate the 60% of people who will respond to that text message and come forward, but the work of general practice being to support those who won't. So the proposal that we are planning to put in place from the beginning of May is that we have 1 site operating in Harrow, and that's at Byron Hall. We believe Byron Hall is the best one, being the most central and accessible. It also offers us the greatest number in terms of space, that we can offer the greatest number of vaccines from that site. So the proposal is that that operates as a hybrid mass vaccination site as well as a GP-led site. The mass vaccination starting to take place there towards the end of April. That will be complemented by GP-led satellite clinics with a much more structured approach for the PCNs working together to look at particular practices where there's lower uptake, and also looking at rotating how vaccines are delivered in those practices. And they're very keen to provide those at weekends for patients. We'll continue our roving teams operating out of Byron, so collecting their vaccine from there and delivering second doses as well as additional first doses for any housebound or care home patients who may have been more hesitant. And what we want to support as well is additional pharmacy sites into Harrow. We're thinking probably at least 3 additional sites, probably in the places where our current vaccination centres are, particularly in Harrow East, so that when the Hive closes, that Harrow East clients can still have good access to vaccination. So just on, I might flick through quickly these last slides because these go into some detail. So this is sort of where we are thinking potential locations. They're shown in the yellow stars of additional pharmacy sites would be useful. NHS England is consulting us around the applications that they're receiving for pharmacies. So we do have some influence over where these are located, and we're definitely feeding back on the basis of this plan. And just moving on to I think I've probably talked through that. This is probably also a bit outdated in terms of those population numbers, but really what I'm trying to do in the slides where we're looking at the numbers is just provide that reassurance that Byron does have capacity to deliver a lot of vaccinations each day. So we've modelled it on the basis that they could deliver 2,500 vaccinations a day, with us adding in extra stations as being part of the mass vaccination site. By doing that, they can deliver all the second doses that are due, as well as first doses. And we're expecting about a good percentage still of first doses to go out there, but also the vaccines to leave those premises and go into practices. So this is sort of the phasing of the work. Things are continuing as normal for now, although second doses are keeping the centres very busy. People will be aware that we are getting a lower supply of first doses over the coming weeks due to the national shortage in an AstraZeneca vaccine, but we expect that to pick up again soon. The model here is that Tithe Farm and Hive close on the 30th of April, and then the vaccine provision moves to Byron Hall at that point. I'll just move through, Carol. In terms of vaccination hesitancy, I think this is really showing the strength of our partnership working with the local authority as well in relation to this. The local authority has been fantastically supportive around community engagement to address vaccine hesitancy amongst particular population groups that we are seeing are not coming forward for their vaccine. That's then really complemented by the work that we're doing in primary care, where GPs are having their individual conversations with patients around their concerns, listening to them, addressing them where they can, and then booking them in to the most suitable venue for them to receive their vaccine, hopefully, if they can become convinced to have that. This just shows sort of a rough percentage of activity. I won't go through this detail. And in terms of the risks that we've highlighted, the operational detail is well underway of being worked through for Byron. We do need to make sure we are influencing these pharmacy sites, but again, the signs look good that local views around where these should be located are very much being taken into consideration. And I think I will pause there. Thank you.
Thank you. Genevieve.
So I wondered if you might just find it helpful. I've got hot off the press figures for Harrow in percentage terms from the Foundry website for our achievements. So just so you know, for Harrow, our care home residents are now at a figure of 90.2%. Our over 80-year-olds are 87.5%. Our over 75s are 93.5%. Our clinically extremely vulnerable are 87.6%. And we have good penetration of coverage in our 70s and over 65s. I think one area I will just pick up is that our social care workers are currently showing at 54.6%. Now, that is possibly because when people are now being vaccinated, they are not, they may have many reasons why they're being vaccinated. They may be in the at-risk groups, they may be social workers, they may be in the age group that we're vaccinating, and so it won't always show up. It depends what button gets pressed at the time of vaccination. And probably the most important figure for us to all reflect upon is that our learning disability registered patients, we're at 65.6%. So these are areas that we have done phenomenally well. I would say we have done phenomenally well, but these are the areas that we are really keen to want to continue to improve upon as we move into the latter part of the programme, before we move into perhaps our younger people who don't have risk factors. We want to make sure that we're doubling back and providing an offer that works for the person, not necessarily just in terms of a one-off offer. The offer is evergreen. It will always be there, and it's really important that we spend our time now focusing on those that need perhaps a little bit more conversation before they attend.
Thank you, Genevieve. There's 3 hands up. If we take all 3 in the same time, because I'm conscious of the time. So we've Councillor Janet Moat, Marie Pate, and then Councillor Gazanfa Ali. So Janet, do you want to go first?
Yeah, thank you very much, Chair. With regard to the surge testing, I'd like to say a very big thank you to Carol and your team for keeping the ward councillors in the loop right from the beginning. giving us a heads up was much appreciated. So thank you very much, Carol, and your team. It was an absolute, it was really wonderful for us to be right there in the forefront with everything right at the beginning. So thank you for that. And secondly, with regard to the delivery going to Byron Hall after the 30th of April, will there be Pfizer and AstraZeneca vaccines available for people for their second doses? Thank you.
Thank you. Marie?
Hi, thank you. All I can say is excellent. I think the work that you're doing has been absolutely fantastic, and I wouldn't even comment any further than that. Other than having just had my vaccine, I'm still feeling rather ropey. But apart from that, no, brilliant news. My question really related more to the returning to the new normal for services from the GP practices. Just to plea, can we, one, keep Healthwatch informed about how those services are changing so we can inform the people that contact us, and if in any way we could gain a level of consistency in the messaging that is coming out from the GPs. Genevieve and Lisa have both been brilliant in supporting queries we've had in the past, but if we can get it right at that point, it will save headaches for all of us. But no, well done everyone, thank you.
Thank you, and Gazantha.
Thank you, Graham. My just a word of appreciation. Harrow, well done. I think it's a teamwork with council, our GP practices, health, well-being board. Everybody's involved, I think. And as Graham, you know that Harrow, I think, is among top 2 councils in London who are going. I mean, very well. And hopefully, I think second jobs will achieve that one also. Thank you very much, the team. Thank you.
Thank you. Did anyone, Carol, did you want to respond to?
Well, it's very nice to be thanked, Janet. Try and keep everybody informed. I think, with just mentioning that there's a South African variant does worry people. But I think what we've got in place is a very good system of trying to identify if we've got any further cases. I'm not actually expecting to find further cases. Most of the London boroughs haven't actually found any. So, and I think it's going well. I think the local population seem to be accepting it quite well. And I just echo what everybody else has been saying. I think Team Harrow have been doing a fantastic job. We're not completely there yet, but we are getting there. That light at the end of the tunnel is getting bigger every day.
And Genevieve.
Yes, thank you. And I would also thank Carol for fantastic communication around the South African variant for our GP colleagues. That's been really fantastic. To pick up Councillor Moat's question around what will be the vaccine type coming into the clinics, the reality is actually we don't know. That's the honest truth. The vagaries of this programme are that it's very much led by the national team. We know we are seeing our second doses of Pfizer coming in now through to people who had Pfizer at the early part of the programme. Predominantly now we're moving into a patch of AstraZeneca delivery, but we know that these are not the only 2 vaccines that have been approved. We've also had approved Moderna, which is another vaccine, but we don't know when that will come online. So all I can say is that we will absolutely let people know what's around in terms of the vaccine, but the message very, very clearly is that we encourage people to take the vaccine that they're offered. You'll see that there's lots of very eminent professors who have absolutely endorsed that approach, and I think that for us, it's been a phenomenally successful campaign, and given the number of vaccines that have been given, the level of issues that has arisen is really tiny. So the most important thing is that we get the vaccine into people's arms the soonest possible. I don't know if Lisa wanted to pick up Marie's point.
Well, there's quite a few hands, but I just I'm conscious time is 11:30. We have one more report to go, but Lisa, we've got Lisa, then Janet.
Yeah, I'll be very, very quick. So sorry, just to reply on the second dose issue as well. So I wondered for your question, because the mass vaccination sites will just be delivering AstraZeneca. I think that might be sort of where the question, the fact that ours is a hybrid, they can deliver both Pfizer and AstraZeneca. So they'll be able to deliver the second doses. There's probably very few first doses now that are Pfizer. It's majority of AstraZeneca going out, but yes, they will deliver all of the second doses there. Marie's point, yes, absolutely. Let's keep talking as general practice returns to normal. This sort of opportunity to stop and restart really is a perfect opportunity for reflection of what we want to go back to, but also what changes have worked and what we need to keep. So and we will be encouraging practices and working with them to reflect on those things as services start up again. So hearing the patient voice in that equation is going to be really important too. As we start seeing the timetable emerging for which services are being stood back up at which point, I'll absolutely be sharing those. Thank you.
Thank you. And Janet, you have a quick point?
Just very quickly. Thank you, Chair. Will it make a difference then if you mix and match the vaccines? If you've had Pfizer, then have AstraZeneca, will it make any difference, or is that quite acceptable nowadays? Thank you.
No, it is the Green Book, which is like our vaccination Bible, basically tells us that we should maintain the same dose for the first and second doses. So everybody that's had a Pfizer dose, we've got the second doses sitting in the freezer somewhere ready to give them the second dose of Pfizer, and the same with AstraZeneca. There's a few tiny issues where some people kind of like can't have the second dose for a number of different reasons, and if that's the case, then we are allowed to switch it. And given the nature of the vaccines and how they actually work inside the body, it is possible to switch them, but we're trying to maintain vaccine consistency.
Super. Thanks very much indeed.
Thank you. It's been a very interesting update. As people have said, it got mobilised very quickly, and the vaccines rolled out very quickly, and the take up in Harrow has been very strong. We just got the challenges ahead of the people who probably don't or haven't access to vaccine at this moment in time, and there's a lot of effort being organised to arrange that to happen. So the recommendation is that we note the report. Is that noted? No one's nodding their head. Oh, well, have fingers up. That's good. We now move on to item number 10, which is our final report, and it's from Marie, which is the Healthwatch Harrow report on GP and dental services access report. So, Marie.
Morning, everybody. I'm sorry, I'm just trying to. Has that shared the screen with you?
It has, yeah. Yeah,
brilliant. Thank you, and thank you for the opportunity just to provide some high-level feedback on our report. I don't propose to go through the whole report because I think they might be asleep, but what I thought I'd just cover off is some short slides in terms of the key findings that came out of it. From a start point, I think it's just clear to say the background. I think most of you are aware of what the role of Healthwatch is. Our role is to gather intelligence and to collect evidence. There is there's always been access issues to GP practices. I don't think it will ever fully go away, but over the last year that's been increasing, as well as a lot of concern about access to dental services. So that's really what triggered us in doing a little piece of work around this, particularly if you follow on from the fact that back in 2017 Healthwatch did a report at that time as well. There is a general awareness of the issues that need to be addressed. I don't think I'm going to present anything that people don't know, but I would say is we were sort of slightly cautious in doing this piece of work. Bear in mind how hard everyone within the NHS is working at the moment. So this is in no way meant to put a damper on all the hard work that's going on within the GP practices and elsewhere, but it's trying to get the balance of recognising how everybody's operated within the pandemic, but also that patients have got a right to be able to access services. So if we please take it in that vein. And the other thing I would like to clarify right at the very start is the feedback has in no way commented on the quality of care that people have received. The main issue is really around getting access. So I think it's useful to keep that one in perspective. The key issues that came out of the report were the GP telephone systems and online booking systems and the issues people have of trying to get through to GP surgeries. I think the quote for me that summed it up was I dread needing to make an appointment to see my doctor. And again, I would state the feedback is across the whole of Harrow. There are differing responses to different surgeries, so please again bear that in mind. The commissioning of the NHS dental care, the key thing that seems to be coming out is the fact that the commissioning doesn't meet the demand for services. There's lots of feedback we're hearing about. People are being told that the NHS service can't support them, but if they pay privately, they can, which I think is quite concerning. With regards to the BAME communities, again, what came out that they are disproportionately affected. Key areas seem to be around language, knowledge, and lack of digital access. And one of the things here which sort of supports was we did a piece of work, Healthwatch, with Ridgeway Surgery and the remaining community, where we held an outreach session and identified what the services the remaining community weren't accessing, and then worked with the GP surgery on how we provided information, and then the remaining community actually translated it. So I think there is something here about how we reach these people. I'm probably skipping on to the recommendations there, forgive me. And on a similar vein, there were definitely issues coming through for those people whose English wasn't their first language, where there were mental health and potentially learning disabilities. So those were the key findings. As I say, no surprises in there. The recommendations we came forward, keeping to those themes, were about asking the CCG to work with the primary care networks and the GP surgeries to improve telephone access and online booking. The second recommendation was to NHS England to ask them to look at the commissioning of how they commission the dental services within Harrow. I don't profess to be an expert here, but what I'm hearing is it all relates to the units of dental activity and the amount that's commissioned, and feedback is that that doesn't meet the demand for the residents of Harrow. Third recommendation was what I've literally just talked about, was how we work with the BAME communities to actually improve and identify where the issues are to see how we can address them. And the fourth issue was, the fourth recommendation was around how the primary care networks and the GPs work together to tackle the areas of language, mental health and learning disabilities to ensure that the access is accessible. In terms of response, I will say CCG have been, both Genevieve and Lisa have been excellent in coming back to me and moving things forward. So the feedback that I've received is that the executive team have agreed that they will support general practices in their transition back to normal business arrangements, supporting access, particularly telephone access, as this will be a critical component, and that they're looking to work at how they get the right capacity and balance between face-to-face conversations as part of that as well, because our feedback has been really mixed, what the issues are. So I think that's a really positive step. What it also identified was there's been some of the access issues could be well related to the fact that there's been a lot of COVID vaccination queries, and that's been clogging up phone lines and getting through to GP surgeries. And the CCG have worked with Harrow Council to promote the Harrow Contact Centre as a place that people can send their queries to with regards to vaccination, COVID vaccination queries. And also looking at how extended GP access arrangements can support some of the issues that patients are facing. It's about encouraging practices to re-engage in using these extended services, and to also look at how we additionally access things like NHS checks and things that have been paused over the period which we've talked about earlier today. Final 2 points were, there were a couple of surgeries where we repeatedly have concerns, and these were raised, and I'm delighted to hear that these have been picked up with the surgeries to the point that we've even seen an action plan on how they're going to take things forward, which is really positive. Thank you for that. And a commitment that they're going to continue to keep this area ongoing. So from our perspective, it's not necessarily here's a plan and here's a date, but I don't think we can work in that environment at the moment. But it was really positive to have the support of Lisa and Genevieve in addressing these and building it into the roadmap as we move forward, which I think for me is the key thing. With regards to NHS England, and if anybody can offer me any help here, I'll gratefully receive it, because I'm not quite sure where I go to next. The concerns we raised, they did respond, and we have had a two-way communication. The feedback generally is around, their view is that the issues are due to the reduced capacity because of the controls they've had to put in place due to the pandemic, which I fully appreciate and understand. Their view is that if a patient is seeking an earlier routine NHS appointment than is currently available, a private appointment may be offered, which was sort of missing the point of what we were raising. That may be the case in some circumstances, but many of the instances we are hearing about aren't just somebody looking for an earlier appointment. I mean, we had a quote yesterday of a parent trying to find an appointment for treatment for their child and is told that she can have it if she pays. And that's for a child. So there is a bigger issue here. They also didn't in their initial response pick up to the commissioning issue, but I did get an email from the Commissioner this morning who her line is still that she believes the commissioning is adequate for the capacity required in Harrow and that this is a North West London wide issue, which it is because it's something Healthwatch England have picked up. But yeah, there's no real acknowledgement that they see that there's an issue in Harrow. So I'm not quite sure what my next step on that one is. And I'll just move on to my last slide, if that's okay. Is CQC have responded. We do meet with them on a regular basis, so they are aware where we have issues and they are monitoring things. So I'm sorry, I'm doing a real skip through this. I do talk very fast, forgive me. In summary, I just wanted to say that the response from the CCG has been very positive and they're taking steps to look at these issues, which is great. Issues relating to specific GP practices have been addressed, which is fantastic. The CQC are monitoring. NHS England have not responded with regards to the commissioning in a way that I would have expected. And really just a final point for me that this is about working in partnership. We've all dealt in a really hard year. So this is about how do we improve on what's working and how do we help those that suffer from the greatest inequalities. So that was a really quick win through. I hope that made sense.
Thank you very much, Maria. And then the presentation is available on the website if people can go through it at their leisure and pick the facts out. We have two questions at the moment. Gazumpha.
Thank you, Mary, for your report. My just comments are, I really, the issue you raised in your report regarding access. Genevieve, please don't take it at any GPs, please don't take it as criticism or because you're all doing fantastic job, everybody's hardworking. It's my experience I'm just coming from. The access issue is there. I mean, personally, I mean, I tried several times, but I have to wait to have a telephone consultation for a doctor for a week, then have been put through local pharmacists, still waiting for that, and my prescription has been withheld and it has been approved but not signed by a doctor. I mean, these are the issues. I think while we're sitting at home, we are under stress. I'm not talking about me, I'm talking just people, you know, because it's almost a year people have gone through this difficult time. And when you don't receive a response in time and you can't consult a doctor within a week, then it puts you under a lot of stress. I think we have to do a little bit more work on these issues, as Mary has raised in that. And second is this online consultation is complete waste of time. Because my own experience, Genevieve, I just wanted my 6-monthly blood test. And I went to the reception. They said, no, you have to complete this online consultation. It took me 10-15 minutes and there was nothing for blood test. And then at the end, you will not be reported to your GP. You have to phone again to your reception. So then I politely explained to the reception, look, I just want my blood test consultation with a doctor. I mean, these are simple issues that can be solved without making the things more complicated. So this is my just comments. Please don't take it as a criticism. We're all doing very well. We are going through difficult times, and I think this is how it's going to be for a foreseeable future. Thank you very much.
Thank you, Gazumpha. Janet.
Thank you, Chair. Just very quickly, just to say thank you very much for the report. It was super. And just to reiterate what you said regarding the child at the dentist, at our last corporate parenting meeting, we were told that the children, for their dental reviews, were going to be charged. And so that was something that they were going to look into. So just to say that was mentioned at corporate parenting, and just to say, it's obviously being looked into now. But thank you very much, Marie. Thank you.
Thank you.
Thank you. Jennifer, did you want to come back towards the end, or did you want to come in now? We got John. John?
Yes, thanks, Chair. Just to pick up on the point that Marie was saying in terms of the contact with NHS England, I don't know if it's appropriate or not, but what the role of the board is in terms of supporting that conversation, and whether there's anything we as a board can do to improve the response in terms of answering the recommendations that have been made. And it's a question, really. I don't know if it's appropriate or not.
Thank you, John. I'll come back to that one a bit later. Quarter to 12. Genevieve.
Yes, thank you. So actually, I really value all of the points that have been made around general practice, and I take them absolutely in the spirit in which they have been made. And I think that to be fair, the Healthwatch paper has been a good resonator for us to consider a lot of these issues. I am very aware that we are in a situation at the moment where we are potentially putting barriers up, unintentional, but we are putting barriers up to people accessing primary care, and some of that is as a consequence of the pandemic. But let's be honest, this is not something that's new. This is something that pre-existed before the pandemic. So I think we have to take some of these issues on the chin and work out how to do it. It is true general practice is incredibly busy, and it is true that we are actually managing far in excess of the number of consultations that we had before the pandemic. That's increased, and that's before we've kind of like really returned to business as usual. So I suppose part of my plea is to say, yes, keep challenging us, keep holding us to account, but work with us to do it in a way that actually maintains our general practice workforce, because they're all a little bit fragile too. So let's do it together. And I'm really hopeful that actually we can tackle these really real inequalities of access that just perpetuate some of our poorer outcomes. So fingers crossed we all work together to achieve it.
Thank you very much, Genevieve. Marie, did you want to add anything more?
No, that was just say thank you for letting me share the report with you. And I think it is about how we all work together. It's been a difficult year, I think, for everybody. So it's, where we can support and help, that we would love to. So thank you.
Yes, I was going to make a very similar point. We've had a very challenging year, and in a moment we're going to sort of have a minute's silence to reflect that. But I think from what we going into COVID, I wouldn't have believed we'd be talking about online assessments through GP surgeries, all the important things to move things online. And we have had to move some of these things quite quickly, not just the council, but the GPs as well, and also the NHS. All the public sector has moved very quickly, when in the past it's taken time to consult and move a lot slower. I don't think that's a bad thing, moving quickly, but the report shows quite clearly there is some things that needs to be addressed. And I think the GP surgeries and dentists are on board to understand that. And John makes a very good point. As a board, how do we get the NHS to actually respond back to us? And I think we'll have to consider that. I'll speak to Paul a bit later to sort of see how we can do that, because it's a genuine report at a moment in time. And and people, once they get used to services, their views change. There's some that will need better access, and Gazumpha's pointed some of those out as one example. So we need to move forward in that sense, and I think it's an opportunity to sort of reflect on a whole range of things, really. and how we shape things going forward. So thank you very much for the report, Marie. Very informative. The recommendation is that we note the report. Is that noted? Excellent, thank you very much. Right at the beginning of the meeting, we did say that we was going to sort of pause around this time, and I can't believe that everyone stepped to the restricted their comments and contributions that got us to 11:50 when we said we would. So that's very good timing. I think if I start, I don't mind starting some of it, and other people have got time to contribute before we come to 12 o'clock when there is a minute's silence. To me, I've said this on a number of occasions, that we went into COVID at sort of with a lot of services under a lot of pressure. And on the 23rd of March last year, the Prime Minister moved us into a lockdown, which is a completely unusual concept, for people in a free society, that you couldn't go out, you couldn't talk to family and friends. But I think as well, we built on the relationships across this partnership, if we just be parochial about it, all the people within the Health and Wellbeing Board, that partnership and friendship that was built up, and that trust, I think, built up to enable us to get through that first wave of COVID in a very good way. And people that were seriously ill, the hospitals declared a state of emergency, but still people carried on trying to reduce that, the risks down as far as we could. And it didn't stop last summer, because I remember being away and then my wife getting quite annoyed with me because I was still on conference calls as we were trying to rebuild services ready for the next wave that we knew was coming. And I think the second wave probably hit us a lot harder. It seems to have been longer that we've been into this wave than the first wave. But, it's, and in effect, that it's sort of, you just think it was getting to an end, and it started again. So the vaccination, as people have said, has given us a lot of hope, and we can look forward with that confidence. We have that other concern that the pandemic might come back again in another form, and that's what we've got to sort of keep. That's what we're relying on the health service to identify, and while we have public health to keep an eye on all those indicators. But in effect, there's 674 Harrow residents have died through been affected by COVID. There's been thousands been affected by COVID as well. Some people have been mild symptoms, and as Carol can continually tell me, that 1 in 3 people show no symptoms at all, while others have been so seriously ill they end up in hospital on a ventilator. And if you've ever been on a ventilator, it's not something you would ever want to do again. So, I think it is a year of reflection, or a day of reflection of the past. But I think what we've seen from the reports today is that we can probably aim for the future in a better way. We've redesigned services, we've changed things around, we've learned what works well, and I think that's what we can aim to look forward to. So in 8 minutes time, we will stop for a reflection, 1 minute silence, but I wouldn't mind hearing some people's other views of how they've seen the pandemic in Harrow over the past year in sort of, it was a key health professional. Genevieve.
Thank you, and thank you for making this time available for these moments, because I think they are really important. And of course I can't talk for the NHS, but I feel like I should represent the NHS in this conversation, and I know that others will be able to comment. I think I've been incredibly proud of the way Harrow has responded to these extraordinary events, and I mean that in terms of not only the actions of the healthcare teams and the teams that are represented on this call, but actually I think the sacrifice that every member of the Harrow population has made in terms of denying themselves things that they were important to them. And I'm very conscious that as people have lost loved ones, they've been unable to perhaps attend funerals or mourn those victims in the way that they would really want to do. And they are very much in my thoughts, and I'm conscious that we've lost patients in my own practice who have been really part of the practice for a long time, and it's with great sadness that we mark their the illness and the death that they experienced. But I think that through it all, we have grown so much. I was thinking earlier today, my first video call felt like it was strung together by sellotape and a bit of string, and now look how good we are at all of this, and we've learned some new skills, we've learned some new tools, and we've actually made some new friends virtually. The lovely thing is that when you do actually get to meet people who perhaps you've not ever met before, but only ever seen them on camera, you feel like you know them all so well, and it all dissipates very quickly when you actually meet face to face. So I look forward to those moments. But thank you for everything that everybody has done for the people of Harrow and make the NHS journey.
Thank you very much, Genevieve. It's one of those we're getting used to as well, that when reception goes, on mobile, on outside calls. Janet.
Thank you very much, Chair. One of the things I wanted to say about having Zoom calls, phone calls with doctors for consultation and reviews at the corporate parenting meeting, some of the young people said they rather liked that. They felt not so self-conscious as a face-to-face in a surgery. So that's something that's quite interesting that came out as well. And also in the I was in the dialysis unit the other day, and a gentleman had been brought in for kidney treatment on the dialysis. Now, he had been in hospital, I think he said for about 3 months, and for the last 3 or 4 weeks he was in a COVID recovery ward, and he had trouble with his kidneys and was coming down to that. And he said that if you ever meet anybody, just say how wonderful the treatment was at Northwick Park, how much love and care he had. He hadn't seen his family, but he'd been able to see them on an iPad and all of this. But he said, just as a patient in this very sad time, he just wanted to say well done to everybody. And that was really lovely. And I do know that my husband Chris wants to say something as well, sitting next to me, if he can. Go on.
Yeah, as I use not so much the dialysis unit now because I dialyse at home, but at the moment my wife is training to learn how to stick big needles in my arms so that she can put me on the new system, which I'm not quite so keen on because she keeps shouting out 180 every 5 minutes. The whole ward goes up. What I want to say is that whole ward, whilst it's run by Hammersmith in Northwick Park, they have completely adapted to COVID. They are running it through a superb system. They're taking people in from all over London now, running different shifts to work the system. They have adapted brilliantly. I get a COVID test every Monday morning now, whether I like it or not, I get it. And I think the service has been superb. And the integration in, even my daughter who works at Northwick Park, even as a paediatric, she's done frontline on COVID because they've been so short that they've all mixed and matched. Wonderful effort, wonderful.
Yeah, well done.
Chris, thank you. And Kazantha.
Thank you, Graham. Again, I mean, it was fantastic when this lockdown started. Nobody knew how we're going to cope with it, but with the grace of Almighty, I think everybody stood, brilliantly. Our medical, our GPs, they did their best, the hospitals, and particularly the council. We as a councillors, as a council, you, Graham, I think we engaged with the communities to guide them. And Carol provided all the fantastic slides and graphs to update, and she was also involved updating the communities. So we are not through yet. I think we have to wait and see how it goes. And I think we should sit tight and look forward and pray that it get better, hopefully in summer. But my thanks to everybody, to our GPs, our medical staff, the hospitals, particularly the council officers. They did fantastic job helping the community and advising them what to do. So it's fantastic. Thank you very much.
Thank you, Gazumpha. We have 30 seconds to 12 o'clock according to my atomic clock. It's probably out of kilter by now. We should be on Greenwich Mean Time, really, shouldn't we? But no, it's some good words been said, really, and you know, this is sort of there's a minute silence today at 12 o'clock, and if you could light your candle tonight at 8 o'clock. So it's now 12 o'clock. So should we stand for a minute's silence? Thank you very much, everybody. We actually got through all the items on the agenda, and will you all please, Kate, stay safe, and we'll see you all soon. Thank you very much.
Thank you. Bye-bye.
Bye.
Thank you, Graham.